No pressure. Good evening, everybody. Welcome to our live stream. We'll be starting in just over 3 minutes, but you are very welcome to start to introduce yourself in the chat and to get ready for what will be the start of our Lipedema World Alliance presentations for Lipedema Awareness Month. Thank you. And I make it just 7 o'clock Central Time, Central European Time even. So thank you very much and welcome to our webinar on behalf of the Lipedema World Alliance. I am delighted to introduce Dr. Gabriele Faerber, who will be talking to us tonight about what's new in nutrition for lipedema. Gabriele's been a very key part not only of our LWA team, but also of the German S2 guidelines that were recently published, as well as being a really great expert and resource for all of us on the ultra tricky topic of nutrition, because what to eat, how to think about what to eat are always very difficult questions. And I know that Gabriele does an amazing job of supporting her patients with those. So with that, Gabriele, I will stop sharing and let you share your slides with us and hand over to you to introduce yourself and make a start. Thank you. And then we'll do questions at the end. So please do put questions in the chat if you have them, and then we'll scoop them all up and look forward to a great evening.
Okay, thank you very much, Kate, for your introduction, for nice words, your kind words. And I'm pleased to be able to be here a few days before my holiday and share with you what I think is not only new or recent, but also important about nutrition and lipedema. But before I touch or go into nutrition itself, I think that I give you a few remarks on the guidelines that are, you know, that are connected to the issue of nutrition in some way. I'm not going with you through the whole guideline, which, by the way, will be translated or has been translated, but I have had to make a lot of corrections. So it will take some time, but eventually it will be available in English online. So what are the goals of nutrition in or for lipedema? There's certainly a need to manage weight, especially if the patient is overweight or obese. But of the same importance, I think, is reducing symptoms and improving functionality and quality of life. And that is exactly what we have also what you have expressed in our guidelines, which I come to later. So the guideline itself is a synopsis of the national and international evidence that was available at the time, and since then already 2 or 3 new publications, papers on nutrition have been published. So it's an ongoing process, of course. 12 scientific medical societies took part. At the end, we underwent a structured consensus process, and the aim of the guideline is to provide recommendations for the best possible treatment for patients with lipedema. And in order to do that, it gives an overview on the diagnosis, on differential diagnosis, on the therapy options, self-management. And self-management, of course, involves nutrition as well. Now, as to the issue of obesity in lipedema, I want to stress something. The definition of lipedema is, in our view, is a painful symmetrical accumulation of subcutaneous tissue in the extremities, almost exclusively in women. And if there are no symptoms, if there's accumulation or disproportion of fat, but no symptoms, we don't call it lipedema. That is slightly seen slightly different in various other countries. But what I want to stress is obesity and lipedema are not mutually causal. That means obesity is a common coincident disease, but obesity does not cause lipedema. There is some myth around that first there is obesity and then lipedema starts, which is obviously nonsense. Lipedema is a condition that is, in most cases, in some way, which we don't really know about, is inherited. And obesity can cause secondary lymphedema. That's another thing. It's not the lipedema itself. The coincidence of obesity, or the ratio is in literature is very high, but we have to acknowledge that usually or generally classification of obesity is done according to BMI, and then it's over 50 up to over 80%. But the BMI-based classification is not appropriate for lipedema or in lipedema patients because the disproportionate distribution of the adipose tissue can cause false high values. So this is important to know. I'll come back to that later. What we do know is that volume increase correlates with weight gain. So more weight, more volume, but symptoms and pain don't necessarily. They can increase in phases of hormonal changes, also with weight gain and with stress, for instance. And there's no correlation between the severity of the symptoms, pain, with any stage. We see young, normal weight patients, even very low weight patients who can have a very high pain score. So lipedema is a chronic disease, but it's not necessarily progressive. The progression depends on various factors. Weight gain causes more disproportion, more volume. Hormonal change usually is associated with more pain. BMI is not appropriate. I said that before, because it overestimates overweight and obesity in lipedema patient. That is why we published that together with Erich Brenner, Isabel von der Cordero is also founding. They are all actually founding members of the LWA, all the authors that you can see here. We think that waist to height ratio is the appropriate tool, because it's independent of the total weight as well as of the weight of the legs. I get often asked, why not waist hip ratio, which seems to be more well known. But here, on the contrary, you can underestimate obesity is if there is a really massive gluteal disproportion. Then the waist can appear normal in the ratio. So overall, we prefer waist to height ratio, and you can see what I mean on this slide. BMI, weight divided by height, waist to height, waist divided by not weight, but waist divided by height. And so there's no influence of the weight of either the total body or the extremities. I just quickly show you that it is quite easy to estimate, even for patients. Up to the age of 40, it should be, normal weight should be not more than 50% of the height. And from the age of 50, it can be up to 60%. So it's quite easy even for patients to estimate that. So again, this was published in a nice journal, international journal, and I just want to come to an end about this, but I want to say that neither BMI nor waist height ratio, of course, are tools to diagnose lipedema. You have to do that by your clinical exam, but it's a way to exclude or confirm obesity. So this is the last picture, the last slide on this issue. You can see that most of the on the left-hand side, there is the BMI classification, on the right-hand side, waist height ratio, and you can see that most of the patients fall down by 1 or 2 stages if you use the waist height ratio. Coming to our most important issue tonight, literature and literature on nutrition and lipedema. Each time when I talk about that, I perform a PubMed research before, and each time there are more hits, there are more papers, which is quite encouraging. But you can see that it actually only started in the year 2021, and 36 of those 40 were published since 2021. So as you can read here, there are quite a few by now on the ketogenic diet, and there are others on the Mediterranean, on a Mediterranean anti-inflammatory diet. So let's start with the anti-inflammatory so-called Mediterranean diet. An Italian group in 2020 studied the potential effects of a modified Mediterranean diet on body composition and lipedema. I think that's very important to note. The body composition, this will be repeatedly remarked upon during my talk, because the body composition is really a healthy body composition is really what we have to aim for. And all those patients were on a modified Mediterranean diet, meaning that it was hypocaloric by 20%, around 20%. And it was, they compared lipedema patients with controls who had no lipedema, and evaluated body composition and other body measures. So both groups, the Mediterranean and the standard diet group, reduced their weight. But in the lipedema group, the adipose tissue of the extremities the reduction was greater, was bigger. And especially important, I think, is that lipedema patients experienced an improvement to perform various daily physical activities related to the loss of their arms and legs, of the fat in their arms and legs. Their quality of life improved considerably, statistically significant. And again, they were able to perform their activities, their daily activities, with less fatigue, pain, and anxiety. And that was why their quality of life was improved. The next paper, also in 2021, was published by a colleague of ours, also a founding member of the LWA, who is actually a surgeon. I find it quite remarkable that he, as a surgeon, wants to prove and to demonstrate that a non-surgical therapy for lipedema is possible. His aim was to show that it's possible to regain and preserve mobility, and that signs and symptoms can be improved. And he did so by using a quality of life questionnaire. And he also wanted to demonstrate that psychosocial well-being can be improved also, among other things, by the good aesthetic results. There were only five patients. That is the problem in many of those papers. The samples are quite small. All 5 patients received at the same time manual lymph drainage, instructions on exercise, and on the anti-inflammatory diet. And in one patient, this was followed by a keto diet. So the lipedema symptom assessment questionnaire improved by 35 to 78%, which is a lot. The volume reduction was between 1,200 and over 10,000 milliliters. And here you see the patient who underwent a keto diet for 6 months after the first 6 months on the Mediterranean diet. And you can easily see this was the start. This was after 6 months. And this is after another 6 months of keto diet. And you can see there's quite a remarkable difference between the two last pictures. So the Italian nutritionist, scientist of nutrition, Roberto Canataro and Erica Tione, Roberto is also a founding member of the LWA. They looked at the link between lipedema and nutrition, and they maintain that the keto diet is more effective than other diets just exactly because it's so anti-inflammatory. There are no glycemic peaks, no glucose peaks on a keto diet, and so there are no advanced glycation end products which are extremely pro-inflammatory. But he also states that besides the keto diet, individual inflammatory factors should be addressed, like gluten or lactose intolerance, dysbiosis, and so on. And they recommend omega-3 fatty acids, supplementation, NAC, polyphenols, which are secondary, they're phytotherapeuticals, if you want, and anthocyanin. Then again in 2021, you see that it all started around the year 2021. A very elaborate review by Leslie Keith and her colleagues was published, in which they described what they had been observing over the last few years. What they saw and described was a reduction in weight and subcutaneous adipose tissue, also in lipedema areas. And also a reduction in pain and a better quality of life, which was independent of the weight loss that was achieved, which is exactly my experience as well. They think that, they maintain that the most important ketone body, beta-hydroxybutyrate, is an anti-inflammatory agent. That is for sure, that has been proven. And that there are positive effects of interactions between the metabolic and the hormone alterations, especially between insulin and estradiol. And besides that, there is also an effect on fluid retention, as fluid retention is reduced. So their hypotheses are that in lipedema areas, subcutaneous fat areas, the adipocytes may require much lower levels of insulin than other adipocytes in order to facilitate lipolysis, or in order to prevent lipogenesis. So that means that adipocytes in those areas can store fat even in absolutely normal insulin levels, or with normal insulin levels, which other cells wouldn't. And that again might explain why a keto diet is more effective for targeting lipedema fat to some extent, where other types of diets don't, because the keto diet reduces insulin to a very low level. And there are a few other possible mechanisms at work, and one of them is the natural diuretic effect of a keto diet, and also by now well-known decreased lymphatic cell permeability of the endothelium of the lymphatics. So the lymph transport is improved. So again, back to Italy. Again, Roberto Canataro, together with our president, Sandro Michelini, and a few others, they followed an obese patient with lipedema for nearly 2 years. The intervention was a ketogenic diet with a caloric deficit of 250 calories. She also was supplemented with omega-3 fish oil, with various vitamins. Vitamin D, I think, is very important. And she lost in those 22 months 41 kilos. And she also reduced all her circumferences, including in the extremities. She had pain reduction, so better quality of life. And this was then described as the possible first step to organize a ketogenic diet, a nutritional protocol. Well, actually, I've been doing this for 16 years, so it's not really the first one, but it's a very good one. So now we are coming to Poland. There's a very active Polish group headed by Małgorzata Jezorek in the University of Wrocław. I don't know how to pronounce it in Poland. And Andrzej Szuba, whose name you see here, is also a lymphologist. And he does the lymph side of the studies, and Małgorzata does the nutrition side. So their first study was on the effect of a low carbohydrate, high fat diet in lipedema patients versus a moderate carbohydrate and fat diet. So it's not versus a standard diet, it's already the moderate carbohydrate is already carb reduced. Yeah, and they looked at the body composition again, the fat mass and volume and circumferences. There were 91 patients in all stages for 16 weeks. They got detailed eating plans with a high proportion of anti-inflammatory nutrients. So again, most of the papers describe a ketogenic plus some anti-inflammatory supplements. Energy deficit was between 15 and 25%, depending on the degree of the overweight or obesity before. And both groups did not differ at baseline. In both groups, all measurements decreased, but the low carb, high fat, so the keto diet, was more effective than the other one, relating to body fat, body weight, as well as fat mass and other circumferences. The disproportion also decreased more in the keto diet. And they also already observed, but did not publish the data at that time, a reduction of pain, swelling, and an increase in mobility and quality of life. that they studied that in another paper, which I'll show you later. So the next paper of the same group looked at lab parameters in women who underwent a keto diet, and they found no change in thyroid values, kidney function. I mean, we've known for years that a high protein diet is not doesn't cause harm to the healthy renal function, kidneys, but it's still around. Many colleagues even are still afraid of the effect of protein on the kidneys. They found, on the contrary, an improvement in triglycerides, HDL, liver parameters, and glucose tolerance, and a decrease in fasting insulin. And the last paper by this group was published just this year. Now they looked at the pain reduction, and you can see in this graph that most of them really went down, and the whole thing went down statistically significant. So that is what they observed in the first study, and they published it in their third paper. But that wasn't the first paper to publish an effect on pain. The first internationally published one, mine were published in German journals much earlier, but this one comes from Norway, and that was also at the end of 2021. Also a very small study. Limitation is small study, small sample, no control. But the aim was to show whether even in a eucaloric ketogenic diet, no weight loss intended, a reduction of pain was possible. So they put the patients on 7 weeks of a eucaloric ketogenic diet. They still lost weight in spite of that, which was probably due to fluid loss and also because the insulin dropped dramatically, so there was less fat storage, if you like. Anyway, the patient's pain was significantly reduced at week 7 of that ketogenic diet, and then they were made to return to a standard Norwegian fare, which is more or less the same that the official nutrition recommendations also in Germany would recommend, and the pain returned to the previous level before the start of the study after 6 weeks of that diet, although the patients maintained their weight loss. So pain was reduced on a keto diet, returned to original values on the standard diet. That is just a short look because it's already 7 years old now. My results were very similar. We had, on a ketogenic diet, we had a reduction of symptoms before and after of almost 70%, from 6.5 on the BAS scale to 2. Then the two very recent studies which were published this spring, only not even 2 months ago. Again, I think it's a Norwegian group or Swedish, I'm not quite sure. And they looked at the effect of a low carbohydrate diet compared with a control diet on pain, again on pain, and they wanted to see whether there are potential associations of changes in pain with the extent of the changes in body weight. Again, 8 weeks, which is not very long, but it's good to it's enough to see effects. A hypocaloric diet, and they looked at body weight, body composition, pain, and quality of life, and that's what they found. In the low carbohydrate keto group, greater weight loss, larger reduction in pain, no association between changes in pain and weight loss. So little weight loss was not associated with little reduction of pain, but it was the diet itself that made the difference, and quality of life also improved. And the last paper I want to share was done by Giovanna Pitotti, who sadly passed away recently and left us, together with Sandro Michelini again, they looked at the efficacy of a keto diet versus an anti-inflammatory non-keto diet. And they found that both diets had a very positive effect on the analyzed parameters, which was anthropometric measurements questionnaire of symptoms and quality of life. But again, the keto diet was more effective than the non-keto diet in reducing the circumferences in the affected areas and improving the main symptoms such as pain, heaviness, fatigue, and swelling. And their conclusions were that a ketogenic diet can lead to a significant weight loss. We have known that for quite a long time now, but it also can improve the key symptoms, and it's considered to be a real therapeutic tool capable of improving the symptoms and also promoting the reduction of circumferences in areas that are most resistant to conventional diets. So before I come back to the guideline, the reduction of pain and symptoms is the primary goal of any therapy, and that is the leitmotif in our new guideline. The therapeutic options don't depend on stages, they depend on the extent, on the severity of pain and symptoms. And the therapy goals are improvement of those symptoms and preserving or regaining mobility, function, and quality of life. The focus is not on weight, the focus is on quality of life and function. And this applies to all the therapeutic options that we've got: compression, IPC, physiotherapy, but also, of course, on the nutritional interventions. So here come the recommendations. We have general recommendations, which they had a very high acceptance of 100%, and they are strong with the wording shall be observed and so on. So goals of nutritional interventions are weight management if necessary, and reduction of symptoms, and require a combination of nutrition, physiotherapy, and if needed, behavioral therapy. And the goals shall be, again, achieving a healthy body composition, not focusing on weight, preserving or regaining mobility and function, preventing progression, and reducing pain and other symptoms. Of course, obesity shall be part of the treatment if it's present, because we know that it leads to volume increase and a general deterioration of the disease. What we then explained after the recommendation was that it's important to achieve a reduction of the fat mass, not muscle mass. That is why adequate protein consumption is important. We want to achieve a healthy body composition, which is understood as a healthy balance between fat mass and fat-free mass, depending on age and sex. We want to achieve this because we by all means, we must avoid a reduction of energy expenditure, basic metabolic rate. We must treat or prevent, recognize sarcopenic obesity, which is not uncommon in obese patients and also not uncommon, especially in lipedema patients. And we must be aware that there is a frequent history of eating disorders. And if that is present, we need psychological support as well. And it's important that that patients are educated early on the significance of both an appropriate lifestyle and nutrition, that the reduction of non-lipedema volume in extremity is possible, because we very often hear from patients that they have been told that there is no volume decrease in the extremity possible, and that is not true. They must be educated that they must avoid short-term diets, but they must achieve a long-term change of nutrition adapted to their individual situation. And then, of course, that obesity can cause progression of volume and deterioration of the condition. And what would be nice if we could also get across that eating habits can influence glucose and insulin levels, and therefore influence lipogenesis and inflammatory processes. Then there are two diets that specific special recommendations, which are obvious for you after you've heard what I told you, what was written in the papers. A Mediterranean diet can be recommended due to its anti-inflammatory qualities. Then we focus on fighting the inflammation wherever and whatever it is. And patients have to be aware or made aware of pro-inflammatory triggers, factors. And a ketogenic diet can be recommended due to its weight-reducing, anti-inflammatory, and pain-relieving effects. And actually, what I do, and what I think is the synopsis of this, a ketogenic diet with anti-inflammatory supplements like omega-3 fatty acids, for instance. And then once you've done that for a while, or the patient has done that for a while, you can slowly adapt the intake of carbs and see whether it has any effect for the worse, and then you have to adapt again. Why is a ketogenic diet anti-inflammatory? Because hyperinsulinemia is per se an inflammatory state, and if you reduce that, you reduce inflammation. Glucose and insulin get stabilized at a low level. Insulin resistance gets eliminated or greatly reduced. We have a reduction of pro-inflammatory cytokines. We have a reduction of arachidonic acid, which is an omega-6 fatty acid. And as I said before, the beta hydroxybutyrate blocks a pro-inflammatory immune reaction and has anti-inflammatory effects because of that. And another effect is the increase in diuresis and natriuresis. Very often, the ketogenic diet has got quite a bad reputation, but it's always considered high fat. Well, that depends. If you don't want to lose weight, then that might be the case in many neurodegenerative or neurological diseases where we know there are positive effects. Then you might have to increase your fat intake because you need more calories. And then you could also use MCT for ketone production. But in most cases, in my patients, we use a protein optimized ketogenic diet, which is not extremely high fat. Weight loss is intended or wanted. Then we need an energy deficit. Proteins help us feel full. They increase satiety. They increase thermogenesis. So what we recommend is a moderate fat intake, more healthy fatty acids. We are not afraid of fatty acids, of healthy oils, but we don't exaggerate the fat intake. And then under these conditions, the ketone production happens from beta oxidation of the body fat, and normally you don't need MCT fatty acids. So just one example, this lady had lipedema stage 2, but she also suffered from secondary lymphedema due to her obesity and from insulin resistance. And after 32 weeks on a ketogenic diet, she lost from her original, I can't see, I think it's something about 127 or 8. She lost nearly 50 kilos, and her waist-height ratio returned to normal, and also her thighs and calves were reduced significantly. That was an obese patient. This patient, although she has a body mass index of 31.1, we wouldn't consider obese because her weight-height ratio is completely normal for her age, but she had very very strong symptoms, sensitivity, spontaneous pain. She used to take 3 to 4 IBUs per day, which are known not to really help. And she was in early retirement due to pain. And she lost 19 kilos in 3 months, didn't have to use painkillers anymore, had no symptoms, could play table tennis in her team again, and was very, very happy. So my conclusions are, lipedema is characterized by pain and other symptoms. All therapy options must aim at reducing those symptoms. And besides compression and physical therapy, the nutritional interventions are an important pillar of the therapy and can achieve reduction of pain and symptoms and of volume, reduction of pain, swelling, and feeling of heaviness. And a ketogenic diet is one way to achieve that. I think, in my personal view, it's the best way to achieve it, to at least try it for a while. I always call it, we are pushing the reset button, and then we take it from there. So thank you very much, and I'm keen to answer your question. I hope there will be many.
Thank you so much, Gabriele. I know I was certainly making lots of notes while you were talking, so it's been a very fascinating and informative presentation. So thank you. So please, everybody, do drop extra questions in the chat as we're going. I've got a question for you, which is picking up on what you were saying, Gabriele, about the reputation of the keto diet a little bit. So the questioner asks, can people who've got lipolymphedema, and in their case, they also have 5 angiomyolipomas or benign kidney tumors, could someone in that situation follow a keto diet? And obviously recognizing it's general rather than personal medical advice.
Certainly, certainly. Lipolymphedema or lipolymphedema is a very good indication, because there, as I said before, we know that the lymphatics benefit from a low to very low carb diet. You can't heal a primary lymphedema by keto diet, but you can certainly improve the symptoms, and especially because lipolymphedema is usually caused by, actually we don't like this expression, this term, because it implies that it's caused by the lipedema itself, but it's usually caused by the increased weight. And so this is a perfect indication. And then what was that about the kidney tumors?
So this person has 5 angiomyolipomas. So because they're benign kidney tumors, benign tumors.
I'm pretty sure it wouldn't do any harm for that. But what I do know is that polycystic or cystic kidneys benefit. That's the recommended diet for polycystic kidneys.
That's perfect. Thank you, Gabriele. So switching kind of quite differently, we've got a question saying, well, if someone doesn't have pain, does that mean that you wouldn't consider them to be a patient with lipedema?
Well, this is a very controversial question. Well, sorry, I think I've just got to open the door, because my dog will start barking, and then we have not much fun. Okay, I'll
go. We'll keep ourselves going while
this usually happens in a Zoom presentation, and most of my talks have been interrupted like that. So anyway,
pain. And
in
I guess
guidelines, we
twofold, isn't it?
The definition of the wording was quite broad. Pain, which might be on touch, on pressure, or spontaneous, or feeling of heaviness, swelling, congestion. So the problem is pain is, and we wrote that as well, is experienced by the individual person very differently. You can't compare pain. The pain threshold, the pain tolerance is very, very, it's different. So, but somebody who's got big legs with no symptoms, no swelling, no feeling of swelling, that we would not consider them to have lipedema. That's what we call lipohypertrophy. This can also be debilitating if it's extreme, but it's not lipedema. And I know these patients, if it's massive, they cannot lie on their backs, their backsides, they cannot lie on their sides. So they have real problem, but it's not lipedema, it's something else.
And for those patients with lipohypertrophy, do they have very similar recommendations? Do you treat those patients as well yourself?
Unfortunately, there are no recommendations really. And this guideline was on lipedema. In case a patient with lipohypertrophy is overweight, she could follow the same diet recommendations, but there is no use for wearing compression unless it can be useful if because it sort of shapes the leg slightly and makes movement easier. But the main problem, I think, for those patients is to come to terms with the shape of their legs. But there are less treatment options than for lipedema.
Yeah, which is, as you say, super difficult, isn't it? Thank you for tackling that topic, because it's one that I think people often find quite difficult. So we really appreciate you tackling it so openly and considerately. We've got a number of different questions then switching back into thoughts around the dietary recommendations you've given. So in no particular order, I'm just going to run down them in the order in which they appear in the chat. So the first person says, with the Mediterranean diet being helpful or beneficial for lipedema, is it okay to eat whole wheat pasta in moderation? So I guess that's a bit about this general topic of the sorts of carbs and amounts of carbs, but in particular, eating whole wheat as opposed to white pasta.
Actually, we've come to realize that it doesn't really make a difference. And wheat especially has a very high glycemic index, glycemic effect. So there is not much of a difference between ordinary pasta and wholemeal. Same applies amazingly, and that has been known only for quite a short time. You know that we Germans love our black wholemeal bread, which is very heavy. And although I'm still convinced that in most cases it's considered to be healthier, the susceptibility or the sensitivity of a person's insulin reaction on bread also differs widely between 2 or 3 persons. And so not for everybody this type of bread is healthy. Even that, although it's compared with whole wheat pasta, it's still another thing. So yeah, one has to try it out. But the thing is, a Mediterranean, yes, you are right, a Mediterranean diet, in my view, includes pasta. This is why I always have, I always have to smile a little bit when I hear the term Mediterranean. But what usually is understood by Mediterranean is lots of vegetables, olive oil, fish maybe, not too much meat, although one can have very controversial discussions about that as well. And what I think is important, whether this is, excuse me, Mediterranean or not, I think what is important is to cut down on chemicals, on conservatives, on anything that our microbiome hasn't been able to grow used to over the last 10 million years. And that is important.
So your recommendations are on the more unprocessed, simpler side, as opposed to the more processed carbohydrate.
Not only carbohydrate, also anything else, anything that comes in a tin, except for tomatoes maybe. But anything that has been prepared by somebody else and put in a glass or tin is suspicious, especially if it's got more than 2 or 3 ingredients and those E numbers, which you don't know what they are.
I mean, I'm still a fan of Schwarzbrot, Gabrielle, so, you know, you're paining me here. But you have led us beautifully into another question, where the questioner says, can they follow a keto diet without eating a lot of meat? And obviously, as a vegetarian, I'm very much in their camp.
Yeah.
They go on to talk a bit about inflammatory responses, but I'd like to break the question into a couple of parts. So could you start with talking about meat and vegetarianism for lipedema and your views of ketogenic, vegetarian or vegan diets?
It's perfectly possible to follow a keto diet as a vegetarian. It becomes difficult, and I think it becomes unhealthy if you want to be on a vegan diet. But as a vegetarian, you can fall back on fish, maybe, if you are what's it called, a
pescatarian.
But you've also got eggs, which unfortunately don't contain as much protein as one would wish. We have the dairy products. What I think is important is I always try to bear in mind the conditions of the animal that I eat. Yeah. So even if you eat meat, it depends on what are the living the living conditions of the animal that you eat, and that also applies to their products. So dairy should preferably come from pasture raised animals, and you can eat cheeses. So there are quite a lot of, and then of course there is soy, which is also controversial. I think tofu might be all right, or is probably all right, but I don't think it's healthy to exchange dairy products for soy milk, soy whatever, yogurt, and so on. I think there are other options maybe.
So perhaps more of the sort of fermented soys, like the tempehs and things.
Exactly. Yeah. Tofu is fermented, yeah.
Yes. Yeah. So the questioner goes on to talk a little bit about they feel that what they have is an inflammatory response to meat. So they prefer things like avocados, olive oil. So do you want to just talk a little bit about how should people figure that sort of thing out? Because we've got a couple of questions that say things like, how do I know how many calories to eat? And so I think a question for people is how to personalize this and how to figure that out. So could you maybe offer a few thoughts about that? When someone's trying to think, I feel like I have an inflammatory response to this food, or how do I know if I do? Could you start there, Gabrielle? What is an inflammatory response to food?
It's difficult to say, to generalize. I mean, there are quite a few people who don't feel well after drinking milk or having milk, or maybe even dairy products. And I think that it's important to find out about that. I would like to know what the inflammatory after effects of meat are, and I don't know. It could possibly be that it depends on the kind of meat. Is it processed? Is it from intensive, not pasture raised, but mass production? That we know that mass produced meat and what is it? Fowl,
chickens,
chickens and so on. That they are said to be inflammatory.
Okay, so we've then got, and I hope that the person who that was to, if they want to add a bit more about what they think that inflammatory response was or how they experienced it, I think that would be super interesting, both for our conversation
and then also always advocate for leaving it away for a while, see how you feel, and then add the possible food one at a time.
Okay. So you feel that people can respond fairly quickly to things they eat, because that's something I think people wonder is that instant reaction relevant?
Maybe not one day, but
yeah. Okay. So we've got a couple of questions around how someone determines how many calories they should eat. and somebody talking about being in quite a busy job and struggling to have the energy levels in a calorie deficit. So do you have advice for people who are trying to start there? You know, what should I be doing, and then what if I'm struggling?
That is the beautiful thing about a keto diet. You don't realize you are on a calorie deficit.
Okay.
Ketones make you feel full. Proteins make you feel full. Lots of vegetables makes you feel full. So actually, some of my patients have struggle rather with eating enough than not eating enough. The calorie deficit by itself, you remember those studies, those papers, they were not, except for the last one, which was 1200, which I personally think is quite low. But most of them had a reduction of around 20%. I actually can't be bothered with calculating calorie deficit. I give my patients lots of recommendations. Eat 2 handfuls of vegetable with every main meal. So that makes 4 a day. Eat enough protein, which I calculate by 1.2 to 1.5 grams per kilogram normal weight, not actual weight. Eat as much oil as you need for preparing your delicious food. Don't be too mean on the oil, but don't pour it on. And that usually causes patients to reduce the amount of calories they eat because they don't feel hungry. And the most important thing is restrict your meals to 2 or 3 a day. 3 is perfectly fine. 2 is also possible, but don't eat 5 meals a day in between snacks and sort of little things. That is my recommendation.
Okay, so that's perfect.
Yes. That helps to bring the insulin down.
So that's quite perfect, because that would lead us into talking a little bit about intermittent fasting. But before we go there, I just had a request for you to repeat your comments about fowls or chickens, Gabrielle. Could you just rewrap your position on them?
Sorry? What?
Could you just repeat your position on that white meat, those birds?
I think that chicken is not necessarily healthy, or turkey especially. If you look at the arachidonic acid, the omega-6 fatty acid, which is pro-inflammatory, we always used to be warned against eating pork. But if you look at the contents of omega-6 of arachidonic acid in turkey, this is by way the highest, followed by mass-produced chicken. Then there is a gap. Then there comes pork, and then lamb, beef, and venison. So it depends, as I said, it depends on breeding and living conditions, and it's not necessarily healthy because it's white meat. That's all still around, that myth, but it's not necessarily true. If you can find organic chicken, duck, or I love eating duck, then that's fine, but it must not be mass produced.
That's perfect. Thank you. We've got a couple of comments, like people talking about finding the sort of white bird meats perhaps inflammatory, and someone else commenting in support of what you're saying, Gabrielle, about their feeling about how they feel on pork, not beef. We've got a question which is about mixing ketogenic diets with intermittent fasting. So this person found they got quite a good weight loss on intermittent fasting, and their fast days sounds like it was an interesting circular pattern. So they were intermittent fasting 4 days out of 7, 1 day low calorie, high protein, moderate fat, and low carbohydrate. Actually, no, maybe that's all together. On a fast day, it was low calorie, high protein, moderate fat, and low carb. I think that works.
Really fast day.
Yes, it sounds complicated. And they were eating normally in between. So what they're saying is, could they eat ketogenic, have a ketogenic way of eating half the week, and the other half of the week, could they eat the low cal, high protein, mod fat, low carb versions? Does it mix, I guess, is the question.
That is certainly difficult, especially during the early weeks or months, because you take a few days to get into ketosis, and you might not feel really fantastic during those 2 or 3 days. Whoever has ever tried to go on a fasting, prolonged fasting period, like it's very popular in Germany to go to a hotel in a beautiful area and eat nothing and pay a lot of money for it, then you always realize after 2 or 3 days, there's suddenly a switch. A switch must have been done, and they feel perfect. And that is when they are in ketosis. And that happens on the nutritional ketosis scheme. And if you then, after 3 days, go back and eat carbs, you fall out of ketosis again. And you have the same trouble again after another 4 or 5 days. What you can do is, and I'm all for it, after a period of keto nutrition or keto diet, we must always be careful with the word diet, because many people understand, think a diet is a certain short period of time, whereas diet actually means a way of eating. But after a longer period of ketogenic diet, you then could possibly try to go low carb, to go to raise the carbs, and then maybe at some later stage go back to be. So some colleagues recommend switching every few months between a period of keto and then a period of not quite keto. Or what one could also do, or what I always think one has to allow is, once you've trained your body to burn fat, as it were, and to be in ketosis and to use your own body fat as energy, a source of energy, then it's perfectly fine to have a day where you, say a wedding or birthday or whatever, and eat carbs as long as you go back on your keto diet the next day. But if you do that right at the beginning, you'll never really get used, and your body doesn't really get trained in using ketones as energy source.
That's perfect. Thank you, Gabriele. I think there's so much interest. We could keep going for ages, but I'm conscious it's a couple of minutes and then we'll have been on for an hour, so we should start wrapping up. There's a couple of questions around when or how the German guidelines will be available
in English.
In English. Do you?
If I had accepted the translation, it would be online now, but unfortunately that wasn't possible. So I think I get the latest version, which then has to be corrected again by the 20th of June. That is the start of my holiday. It's my holiday job to go through it and proofread it and correct it. And I'm sure, because it's a very specific, the language and everything, it's not easy to translate it, although it's a professional. He's a native speaker, he's professional, he's multilingual, but still there will be some more work to do. So I do hope that by the end of my holiday, I can, maybe.
Yes. Yeah, no, we appreciate that. And I think that's something that's always really important for people to understand, is that it's really important. There's such great easy translation software out there, but that doesn't mean it's understood.
Because, those recommendations, we fought over them, sometimes over every single word. And if now somebody translates them, it has to be in the same way accurate. And that is not easy to be achieved, I think.
No. So we've had some really great questions. And I think probably as the Lipedema World Alliance, Gabriele, there's other things people are asking around things like how they decide if they can eat frozen prawns and, what sort of food, and like, if you turn over the packet of the plant butter and look at that, is that then going to help them decide? So I think there's definitely a lot of interest in this topic, and we could absolutely for sure keep going. The challenge is, I think every extra thing we pick out, more will come. So I think it's a topic that definitely, as the Lipedema World Alliance, we should return to and look at how can we help people bridge the gap between these amazing guidelines and then finding their personal path through. So I think it'll be a wonderful thing for us to do more with you. You have been super generous tonight. I will say that if people would like to put any other questions and thoughts in the chat, it will inform us as an organisation for the Lipedema World Alliance to understand what people's thoughts and questions are, so we can think about how can we provide the right sort of information to people. So if I didn't get to you, I apologise. And if you have anything else you'd love to say, please throw it in there. I promise I will go through everyone and try and think about how we help all our different patient organisations and kind of healthcare professionals provide that information to everybody. But I must, much as I could talk to Dr. Faerber all night, because I think this is such a difficult and amazing topic, we are going to be sort of good and let her go. So I will close by just kind of reminding you all that we have several other amazing sessions with other members of our team. So we have up next is Dr. Sandro Michelini, who is the president of the Lipedema World Alliance. He is here next week on Wednesday, along with Dr. Jose Luis Samaro, and they're going to be talking around Dr. Michelini will cover the contribution of scientific research to clinical practice, and Dr. Samaro will talk about clinical diagnosis of lipedema and differential diagnosis, so differentiating lipedema from obesity, cellulite, and lymphedema. So I think that'll pick up on some of the things that relate to some of what Gabriele was saying. Then on the 24th, on Monday, we have an amazing update from Dr. Philip Krupa, who is going to be talking about a process we've been going through within the Lipedema World Alliance called the Delphi process, which is to produce a consensus-based position paper on lipedema. So he's going to be giving some interim hot off the press results before we've even published. And then on the 26th of June, we will be closing these formal sessions with Dr. Isabel Forna-Cordero, who was in some of the pieces that Gabriele was talking about tonight, and Dr. Thomas Wright. And they are going to be covering, in the case of Dr. Forna-Cordero, what we know about compression. She's got some really cool and amazing things to say. And again, like ways of eating, it's a really live topic for many of us. And then Dr. Thomas Wright is going to be talking about a really interesting topic he published on a few months ago, which is about the benefits of lipedema reduction surgery in improving leg pain, improving mobility, and knee mechanics. So an absolutely amazing set of speakers coming up. I'm super excited. I'm now 3 minutes over the hour, so I'm going to thank you so much, Gabriele. It's been amazing. I wish I could keep you and take you everywhere with me. But until I can do that, we're going to have to just look at doing sessions like this and putting as much as we can out through the Lipedema World Alliance. So thank you ever so much. And I will leave everybody with that request that you join us again soon. And I wish everybody a wonderful evening. And thank you so much, Gabriele.
Thank you. Have a nice evening. Bye.
You too. Bye-bye.
Thank you.
And now I just have to...
So, are you still there?
I am. We're just stopping streaming 1 second.